So without wasting too much time, I'm going to start talking about what these fistulas are. So endovascular AV fistulas. So as far as my disclosures are concerned, I'm a speaker and trainer for Avenue Medical, the company that makes ellipsis. And I'm also a speaker and trainer for Medtronics. So the first question is, why create AV fistulas? Why not just leave tunnel dialysis catheters? So AV fistulas are probably the most reliable dialysis access. They have been shown to improve morbidity and mortality when compared to tunnel dialysis catheters. There are fewer access-related infections or other problems that happens. And a well-created AV fistula will require very few interventions. And at the end of the day, it's really the patient satisfaction that they don't have to go around with a catheter sticking out of their neck or their chest. And this is something that they can easily hide. The ideal AV fistula should be easily accessible, easily cannulatable repeatedly, and should have adequate blood flows to support hemodialysis prescription. It should require minimal interventions and should cause the fewest problems, such as Steele syndrome, such as congestive heart failure, neuropathy. Sometimes there's skin erosions that are associated with fistulas, or any other kind of access problems that can happen with the fistulas. That's where the percutaneous fistulas come in. So they're minimally invasive. So just to give you an idea that there are so many fistulas that we have done in our practice where the patients had actually been turned down because they were not good candidates for anesthesia. So anesthesiologists had refused to put them under or give them any kind of anesthesia. And because of the minimally invasive nature, we can do these just under local anesthesia. They require a very short maturation time. Within generally 4 to 6 weeks, we have started using these fistulas in some cases, and that has been successful. There's also a reduction in the failure rate of these fistulas compared to the surgically created fistulas. They require fewer interventions. And there's also a probable high output congestive heart failure benefit because these fistulas are created in the proximal radial artery. And because these fistulas do not have as high a flow as a surgically created fistula, there's supposedly a CHF benefit from these fistulas. We don't know that. We don't have the studies to prove that yet, but there are studies that are being conducted. There's less incidence of Steele. There are expanded AVF creation site, so where we can create these fistulas. And if at the end of the day, these fistulas don't work out, we have not really gotten rid of any surgical sites that could have been used for surgical fistula creations. Now, the disadvantages, the learning curve for the interventionalist and surgeon who wants to do this procedure, and more importantly, the learning curve for the cannulator. These fistulas are not the same kind of fistulas that are surgically created. They are not as bounding, as strong as the surgically created fistulas. So the cannulators, the nurses or the technicians who normally cannulate these at the dialysis centers, they find it a little bit difficult. But again, as over the past 1.5 years that we have been doing this, we have noticed that the technicians and the nurses are getting better at cannulating these fistulas. Now, as part of the interventionalist and surgeon skills are concerned, you will require ultrasound, very good ultrasound skills to not only identify the patients who are good candidates, but also to do the procedure. And also, not all patients will meet the criteria for a percutaneous fistula placement. Now, just like Dr. Bala pointed out, there have been no innovations in the past 50 years, ever since Semino and Brescia identified or created the initial fistulas. There really have been no innovations up until now. AV fistulas, the traditional sites are the radiocephalic or proximal radial or the Grax fistula, the brachiocephalic fistula, or the brachiobasilic fistula. These were the only sites that were available to us. Now, with these percutaneous fistulas, what we do is we require on the perforator vein. What is the perforator vein? It is a vein that connects the deep venous system in your forearm to the superficial venous system in your upper arm. So basically it lifts the blood that is circulating in the radial and the ulnar and the interosseous veins and brings it up to your cephalic and basilic veins. So we rely on the perforator vein to create this connection. And that gives us a few additional sites where we can create this fistula. One of them is the ulnar artery, ulnar vein site, and the radial artery, radial vein site, which the wavelength system uses. And the ellipsis basically relies on creating a fistula directly from the perforator vessel to the radial artery. So the perforator vessel actually dives down right at your antecubital area from the median cubital vein and connects to the deeper vessels. So as it's diving down, it abuts or travels right next to the radial artery or the proximal radial artery. And that is the site that we use to create the ellipsis fistula. So who is a candidate? Patients who have a good inflow, meaning arterial sizes more than 2 millimeters. And when I say artery, I'm talking about the artery at the site of creation, which would be a proximal radial. Patients who have good outflow, superficial veins more than 2.5 millimeters or 2 millimeters. An adequate perforator vessel, again, 2 millimeters is the size that we look at. And patients who have adequate creation site. So if you have a good vessel at the creation site, at the point where the fistula would be created, but the ulnar or the radial artery does narrow down as it goes down into the forearm, they would still be good candidate. So they might not be a good candidate for a radiocephalic fistula, but you could still create a proximal radial artery or the ellipsis or the wavelength fistulas. One of the things that we have to look for in these vessels are the outflow vein dominance. So if the dominant flow goes to the basilic vein, these fistulas will actually turn out to be basilic dominant. Now, will they require transposition? Not always, and I'll talk about that towards the end of our discussion. But ideally, what we look for are patients that do have good cephalic outflows. And that makes our life very easy and the life of the technicians and the patient as well. So as you can see, the surgical fistula requires an open incision, and it's a direct connection between the artery and the vein that's surgically created. With the endo AVF, the wavelength requires radiofrequency energy, where the radial artery and radial vein, or the ulnar artery and the ulnar vein, they're approximated with the help of magnets, and a hole is burnt. With the ellipsis, it's actually thermal energy that's used right at the point where the perforator vein is crossing the proximal radial artery. So again, I'm going to talk about some of the data from the US perspective, so you will have to excuse me on that. But the Food and Drug Administration is the key agency over here that approves the use of any drug or any procedure. So after studies that were done for many years, and most of the studies, initial studies, actually came from South America and Europe. And after having gotten approval in Europe, I think in 2016, in June 2018, FDA finally gave approval. Then finally they decided in January 2019 that they would start paying for this as well. Then further data started to come out. The 2-year ellipsis data started to come out as well. ASDEN, which is American Society of Diagnostic and Interventional Nephrology, they finally came out with a white paper. In January 2020, there was a meta-analysis that showed how these fistulas worked. And since then, there have actually been so many papers that have come out that have shown how these fistulas work. Now, I'm going to make it very short and simple. My goal is not to train you how to do these procedures, but just to give you an overview. So the WaveLink is a 4-French system that requires 2 catheters. So you will either access the brachial artery and brachial vein to go ahead and direct your catheters to the radial artery, radial vein, or the ulnar artery, ulnar vein. Or you can access from the radial artery, radial vein in the distal forearm, or you could actually access one catheter in the radial artery, the other one in the brachial artery and the brachial vein. So there are many different ways and permutations and combinations that you can use this. It requires radio frequency. You do require X-ray, meaning fluoroscopy for this. And you require both venous and arterial access. There is no fusion of the anastomosis. So meaning that it's radio frequency that creates a slit between the artery and the vein. And at the end of the procedure, as you're pulling yourself out of the brachial artery, or the brachial vein, I'm sorry, we usually end up coiling the brachial vein to reduce the flow from there and direct the flow to the superficial vessels, namely the basilic and the cephalic veins. The ellipsis vascular access system, it's a single catheter, 6-French system that's ultrasound guided. It's purely ultrasound guided. There is no X-ray, there's no fluoroscopy involved. It's just purely venous access. So most of the time you end up accessing the median antecubital vein, and you guide your needle down through the perforator to the point where you directly puncture into the radial artery. And from that, you use the catheter, the ellipsis catheter, that has a ceramic plate, basically, that helps to permanently fuse the anastomosis. In this case, what ends up happening is you require a PTA at the time of creation. So after we have created the fistula, which usually is almost about 2.5 millimeter in width, we use a 4 or a 5 millimeter balloon to angioplasty the anastomosis immediately after creation. So when it comes to the comparison, I basically talked about the details of this. We require thermal energy for the ellipsis, radio frequency for endovascular wavelength. The creation site is the perforator vein and the proximal radial artery. This could be radial or ulnar. The perforator has to be more than 2 millimeter. The creation site has to be less than 1.5 millimeter apart between the artery and the perforator vein. In the wavelengths case, it does not matter if the perforator is far away from the proximal radial artery, because you're not creating a connection with the perforator vessel itself. It requires ultrasound on the ellipsis side, and this requires fluoroscopy on the wavelength. Now, even though this does require fluoroscopy, you have to screen these patients with good ultrasound technique. Now, the technical success for these patients is almost 95 to 97% for the Avenue, 97 to 100% for the wavelength. And this is the meta-analysis that I was talking about earlier. The maturation rates at 3-month time is almost anywhere from 85 to 100%, 91 to 96% for wavelength. The time to dialysis on an average is about 100 days for the ellipsis and 112 days for wavelength. And I think, and this is something that we saw in our practice as well, the major hurdle was training the cannulators or the nurses or technicians. Once they got trained this time, in our practice, it was almost 160 days when we started doing this. From that, we have actually brought it down to less than 60 days now from the time of creation. Now, these patients or these fistulas, both of these techniques, the primary patency is not as good. So they do require some additional work. But the cumulative patency you will see is almost 87% for avenue and 84% for wavelength. And the patient eligibility, like I talked about earlier, that not all patients meet the requirements for creation of these kind of fistulas. There are about almost 45% patients for BARD and about almost 44% for wavelength. Now, at the end of the day, if I were to give a one-line synopsis for all the papers that have been published so far as the differences between these fistulas are concerned, I would say other than the technical details, other than the act of creation of these fistulas, the fistulas that are created are exactly the same. The site might be different where the fistulas are created, but the technical success, the maturation rate, the 6-month patency, the 12-month patency, procedure-related complications, they're very similar. The wavelength, they tend to have a little bit more complications as compared to the ellipsis, mainly because you're accessing the artery directly. But other than that, really, the fistulas are basically the same. Now, I wanted to actually show this study, the comparison between surgical and endovascular hemodialysis AV fistulas. So these fistulas, whether you compare them to each other or to the surgically created fistulas, are very similar. And the cost in the US of creating, now I know the cost in India is totally different, but the cost of creating a surgically placed fistula compared to an endovascular fistula is significantly different in favor of endovascular fistula, because these patients do not require going to the hospital. They do not require any pre-surgical major interventions or major clearance. They do not require maturation procedures as much as the surgically created fistulas. The cost tends to be lower. Now, that might not be true, and that is, I would say that is definitely not true in your market, which would be extremely different. But as you can see, the difference in expenditure is almost $16,000 for a surgically created fistula versus $13,000. And in the long run, these fistulas have been shown to require fewer interventions as well. So as you can see in this slide, the main thing that I wanted to show is the intervention-free survival. If you can look at the graph. So if you look at the survival, the endo AVF require fewer interventions compared to the surgically placed fistulas. Now, why that might be so, whether because you're directly mobilizing the vessel, you can cause juxtaanastomotic endothelial damage at the time of creation, whether you're transposing the fistula and that causes further endothelial damage, we really don't know, to be honest. But they require far fewer interventions and tend to be way more cost effective compared to the surgical fistulas. So as I had said, the ASDEN had put out a white paper, and it basically says, in order to realize the potential advantages of percutaneous AV fistula creation within our hemodialysis patient population, it is critical to select appropriate patients and ensure adequate patient and dialysis unit education. And I would underline dialysis unit education because our technicians still do not understand these fistulas well. They need to be provided with sufficient instruction and percutaneous AV fistula cannulation and monitoring.